Looking at before and afters is only one step. When it comes to something as important as a cosmetic procedure, relying solely on a surgeon's portfolio can be a costly mistake. What questions should you be asking that address your long-term health, safety, and results? On this episode of the Doc Dudes, we reveal 5 non-negotiable questions every patient must ask their plastic surgeon, and we explore how you can make the right choice to look and feel your best. Stick around. This is the checklist you need before you book a consultation.
Welcome to the Doc Dudes, your premier podcast for a behind-the-scenes look at the latest in aesthetic medicine. Hosted by the cosmetic surgeons at Garrett Harper Cosmetic Surgery in Charlotte, North Carolina, the Doc Dudes brings you interviews with insightful guests, expert tips from experienced medical professionals, and lots of laughs along the way. And now, here's Dr. Garrett Harper and Dr. Evon Zoog, also known as the Doc Dudes.
Welcome to the Doc Dudes. I am Dr. Garrett Harper, joined by
Dr. Evon Zoog.
We are both board-certified plastic surgeons in Charlotte, North Carolina. Today, we are shifting our focus to a critical part of the patient's journey, the consultation. We're talking about more than just surgical technique. We're diving into the critical questions you need answered to ensure your safety, satisfaction, and comprehensive well-being when choosing a cosmetic surgeon. Why the right questions matter. Boy, this is a great kind of topic, right? So, all right, Evon, talk a little bit about, the illusion of the portfolio. And what I mean by that, I'm going to dive deeper than just before and afters. I'm talking about the whole kind of persona, because you and I both know plastic surgeons these days, man, if we thought they had egos before, it's insane now with the advent of social media, right? So a lot of these portfolios, I would say, are, it's not just going to their website, or it's not just looking at their iPad like, we've had here for forever with before and after galleries. I mean, it's about looking at their social media portfolios even. So talk a little bit about the illusion of the portfolio and just kind of the importance of looking deeper than just what that doctor may be presenting to the publics.
Yeah, and so I guess I'll just talk about my strategy with social media since I've started and tried to build, my practice within this practice in the last 2.5 years. And my philosophy, my thought process was I want patients to feel like they are getting to know who I am before they come see me. I want them to be educated by my content. I want them to see my results. And the reason for that is because plastic surgery it's a partnership. It's not getting your gallbladder out. I want to see you often. I want you to be able to reach out to me and feel comfortable reaching out to me if you have a concern. It's a partnership. It's not a transactional thing in my mind. So that's how I want to kind of advertise myself through social media.
Right. When I look at some of the plastic surgeons that are out there and I look at their social media, because I think that, people probably look at our practice through Instagram and Facebook more than they do through just getting on the line, right?
Oh, yeah.
Show you how old I am. Going on the World Wide Web and looking at our website, right? Like, I just think people maybe look at that less now, right? And so what I get is I look at some of the theatrics. You and I talked about a couple of plastic surgeons earlier today that are like all just fireworks and light shows, you know what I mean? And it's all about trying to kind of formulate their portfolio of patients. And I've talked about it on some of the behind the scenes podcasts that we've done about how they can manipulate photos and do things like that to try to make their before and afters look better. For some of these procedures, you're never going to see long-term results. It's always going to be an on table, because I can promise you that's the best it's ever going to look. And so, I think that it's one of those things where people can be really entertained by looking at websites or by looking at social media posts by some physicians. But I think that they need to be careful that it's so much more than just the theatrics of what get kind of, I don't know, just shown to them.
They're entertaining.
That's exactly right.
And so the question is, are they great surgeons too?
Yeah. Yeah. And most critical thing there, you can have, millions of followers that love your entertainment, but if your results and if your reputation in your community aren't great, then I asked you today, I was like, about a specific surgeon, I was like, how busy can that guy be? Like, there's no way. Like, he just does so much in the way of theatrical presentations that I just don't think the guy's got to be operating. If he was better at operating, he probably wouldn't have to do all the theatrics, Mm-hmm. And then, let's define or redefine what the term kind of comprehensive looks like for patients, right? When we talk about a comprehensive approach to our patients.
Yeah. So, I think with any patient, any procedure, part of the consultation is I want to make sure that, you're healthy and fit for surgery. And, but what I'm really looking at as well is what their goals are, what their expectations are, for the results now. What are their reasons? What are their intentions for wanting to have a procedure? What is their life like? What's their lifestyle like? How are the results going to change with time? Because some of them may. Yeah.
I also think it's pretty great, right? When we talk about comprehensive, everybody has heard when you're a hammer, everything's a nail, So if you go to some of these plastic surgery offices that maybe don't have estheticians or nurse injectors or lasers or any of those, non-surgical devices, it's like they just want to go to the cutting board all the time, right? And vice versa. You go to med spas who don't have plastic surgeons available, they're going to tell you that they can RF microneedle your face, as well as a facelift. You just can't, right? Yeah. So it's all these types of things where when you're under the care of an office, a practice that can offer every single scenario under God's green earth, then I just think that you've got a better opportunity at getting the right kind of game plan set for whatever your goals are. So from a comprehensive approach, it goes from here, not only our estheticians and our nurse injectors, but also, our weight loss, integrative weight loss program. And, I've sent several patients who have signed up for facelifts and necklace to go see our estheticians, and they need to go on a 6-week regimen. And some of them need laser resurfacing before they come and see me for their surgery. And, a long time ago, before you even kind of came, I had no way of really helping patients lose weight, especially if it was somebody that needed to lose 20, 30 pounds. They don't need to lose so much weight that they need to go see a bariatric surgeon. So I basically was like, go head up to Barnes and Noble. Yeah, go head up to Barnes and Noble and grab like a diet book and an exercise. There was nothing. And so now, being that kind of comprehensive approach to thing has made it to where our patients can just get everything done under one roof, and it's amazing, including their surgery, because we have our own surgical suite,
and
right?
It happens every day. We're one of the coolest things about this office is we're all collaborating together to get the best result for the patient.
100%. I'm constantly grabbing people to come see a patient. I know you're constantly getting grabbed to go see patients, vice versa, and all those types of things. So it really is kind of a unique situation for us, because we're all here, and we've always got a member of each kind of division here at one time, which is awesome. And then I think the most important thing is finding the right fit, right?
I agree.
So what does that mean to you? Because I've told patients before, I said, you're interviewing me, yes, to see if you want me to be your plastic surgeon. I'm also interviewing you to make sure that I want you to be my patient, right? So talk about how important it is to have that right fit.
Yeah, and I tell patients that all the time, because a lot of patients will come in for 4 different consultations from, surgeons from all over Charlotte. Yeah. And when I have a patient like that, I make a point to tell them, I want this to be the right fit, because this is a partnership. It is not just, surgery and you're done.
Right.
And so I really emphasize that to patients, that I want them to, both of us, me and and them to feel like we're both comfortable with what we're about to do.
Yeah, I think you just got to jive with the person. I think that's super, super important that you explain each other's philosophies, goals, kind of how they want to do things, what their life's like, what their timeline's like, and then you get to how good of a surgeon are you? Because obviously that's critical. This is the one area of surgery where, if I took your gallbladder out, you don't know if I did the most beautiful dissection in the world getting it out. You just know if I got it out safely and if your gallstones are gone and if your bile duct's leaking, right? And so if all of those things are fine, then I did a hell of a job. But plastic surgery is a different entity. I mean, you can have total different philosophies when it comes down to different procedures, right? And like why you like to use a certain implant in a certain situation, or why you like to put that implant in a certain place, or kind of, and it's all evolving. So it's really, really critical.
And there really is a big difference in surgeons' philosophies.
Oh, it's unbelievable.
I mean, I've had multiple patients tell me that, their reconstructive surgeon told them, you should be comfortable in clothing and you're cancer free.
Right.
And that's
the goal.
That's not my goal. My goal is for you to look great too and enjoy the rest of your life.
That's exactly right. And to look good naked is what I tell people.
Right.
I'm like, it's not just about looking good in clothes. That's a huge kind of, I don't know. I think it's a separator, right? I think I remember a plastic surgeon that I worked with once looked at me when I was early in my career and he said something like, just put the ball in play. They don't all have to be home runs. And I was like, kind of sounds defeated. I was like, not that everyone can be a home run, but I sure as hell aim for that for every surgery, right? And if I think it can't be for a certain reason, boy, you better tell that patient why ahead of time, because I'd much rather under-promise and over-deliver than the opposite when it comes to surgical results. All right, the top 5 questions you must ask your surgeon about breast augmentation, okay? So let's go over number 1. Evan, what's that question?
Yeah, so very common question. What implant size and shape are best for my body, and how do you determine that? I think we both have kind of similar thought processes on that. We're both biodimensional surgeons. We are going to take a bunch of measurements and choose an implant that fits your body size well. And there's some room to play in there. And so that's where, photos come in. So if I want to see wish pics, I want to see photos of what you think a pretty breast is, because some patients will tell me they'll tell me the opposite of what the photo is that they send me.
That's right. That's always great when it's confusing, right? When they're saying one thing and showing you something different. But yeah, I tell every single breast patient I want wish pics, and let's not talk cup size. Don't even worry about size of implant, because I've got a general range, because like you said, we're going to take measurements. And so that's going to eliminate more than it's going to narrow down, right? We're going to eliminate 95% implants just based on your measurements. And then your pictures that we take into the OR with us, is what we reference. And then it's an art project back there, right? Like it's a combination of the implant in your own breast tissue, and whether that's just placing an implant in a certain position or using a particular profile to achieve, or a width because you like more or less side boob or cleavage, kind of whatever your goals are, then we're able to kind of make those decisions while we're back there, right? Because we have every implant known to man on our wall.
That's the beautiful
right?
thing about plastic surgery is you have to have an aesthetic eye.
Yeah.
I mean, there are different types
There's
of plastic
an art
surgeons,
to it, right? Everybody talks about an art to medicine.
There truly is an art to what we do.
100%. All right. Question number 2 would be, where will the incisions be placed, and why do you recommend this location? Let's go for a standard aug. Sure. Where are you going to put your incision for a standard breast augmentation?
Inframammary fold. We've studied this. Rates of capsular contracture, infection, implant malposition are all higher with periareolar, axillary, umbilical. All those different incisions are not as predictable.
Yeah, I let everybody know your incision's going to be less than 2 inches. I mean, I know that there's a lot of kind of press out there and people talking about you can do it in less than 1 inch with the preservé technique, which is something that we can talk about a little bit. Either way, you put a 2-inch incision in somebody's fold and close it correctly, that thing's going to heal up so beautifully they're never going to see it. And then you don't run the risk of having any scar retraction or anything at the nipple zone. You're not dragging the implant through sweat glands or through, hair follicle areas in your axilla. And so we absolutely 100% know that we've got fewer complications using that inframammary fold
we've had
crease
to fix
incisions.
Complications from all of those different techniques.
Yeah. There's no doubt the inframammary fold incision, I think, is the safest. I think is the best. I think is the least conspicuous of all of the implant incision locations. All right. So this is like the huge debate.
Oh, yeah.
I don't even want to read this. It's terrible. All right. Should my implants be placed above or below the muscle? So it's not really above or below, right? It's in front of or behind, if you really kind of think about it.
It's a better way to say it.
Yeah. So, but talk about it. People are going to talk about above. Am I above or below the muscle, or am I halfway, or half above, half below? What does that mean? I mean, thanks Kylie Jenner or whichever Jenner it was that came up with that.
And that's one of probably the biggest things I've learned from you in the last 2.5 years. And because I was trained in putting implants in a dual plane below the muscle, and I think that's a great option for a lot of patients. But I personally think putting the implant above the muscle, either in the subglandular or the subfascial plane, is a better looking breast augmentation.
Sure.
I think the cons are less than below the muscle.
Yeah.
And we can talk about all that. But every patient that I've taken an implant from below to above the muscle, they think I'm some sort of genius because they feel like it's their breast again.
Right.
And it's not. When it's below the muscle, it feels like it's not their breast a lot of times.
Yeah. I mean, I think that's like, I tell patients, because they look at me kind of like, really? When we say that. 5 years ago, I was 95% below the muscle or behind the muscle. I did a dual plane 2, which means that I was dividing not only the muscle at the bottom all the way to the sternum, but I was also dividing the breast tissue, right? I was separating it from the muscle up to the level of the nipple. And some people, that was very little because they didn't have this broad-based muscle coverage. And so there really wasn't much of a dissection to do. And that's based on your anatomy. But the idea of that was to do 2 things. Everyone thought that the muscle coverage in the upper portion of an implanted breast, looked better because you had less rippling, which just meant that when you stood up in the older implants, the gel was like molasses or honey, and it would go to the bottom of the bag and you'd lose volume at the top of the bag. And if that was in a thin patient and was not covered by the muscle, then you'd get rippling, right?
Yeah, and the reason it looked worse is because the implants weren't as good. The implants are better now.
Correct, which is why nowadays I'm 95% in front of or above, whichever way you kind of want to look at it from the muscle standpoint. I think the only kind of person that maybe is still a really great candidate for being below the muscle is the patient who maybe has a really thin and long torso. Because the width of their breast is what it is. And with a round device, the width is the same thing as the height. So if we have to go with a narrow breast because they have a narrow kind of chest wall, well, if their fold sits lower on their chest, let's say they're 6'1" and 120 pounds and are super, super thin, then I think you're not going to have any gentle transition to that breast implant. Yep. But all in all, when people have this idea of, well, I heard it looks more natural underneath the muscle, I'm like, in what patients? Like, why would it look more natural underneath your muscle if that's not where God intended the breast to be in the first place? And it certainly doesn't look more natural if you get animation deformity, which can you kind of define for the audience what animation deformity is with breast augmentations? Yeah,
so animation deformity is when the implant's below the muscle every time you flex your pec muscle, which is pretty much any time you use your arm.
Yeah.
That muscle squeezes and then the implant shoots kind of down and out.
Sure.
And so one, that looks weird.
Yeah.
And 2, over time, the implants age down and out.
Yeah, they'll get stretched out there.
Yeah.
It also feels weird. I mean, I can't tell you the number of patients that were this kind of submuscular behind the muscle augmentation and said, oh my gosh, when I go to do a push-up, I feel like they're about to like jet out, right? I'll also say I was had a function that was super, super bougie and nice. And gal was in kind of a low cut dress in the front. And so obviously showing the girls off, which was great. And she like went to pick something up and like her whole breast like jumped. And I was like, whoa, like that. Whoa. And so it's just one of those things where you don't get that when the implants are in front of the muscle, right? Like you have a separation of your chest and your breast, which is how we were meant to be. So now with the new devices, you don't get that molasses consistency. It's like a gummy bear, terrible term, but it is. And so it maintains its form, it maintains its shape in any position for the patient, which is amazing. So I'm like 95% in front of the muscle. I think you probably are too.
I have been as well.
Yeah. Even for reconstructions, which is pretty amazing. All right. Number 4, what are the potential risks and how often do you see complications for capsular contracture or implant malposition? And talk a little bit about the Motiva device that people come and ask us about.
So in regards to capsular contracture, we used to see that a lot more commonly, and now we don't. And it's not because of the implant. It's because our surgical techniques have changed and evolved. Plastic surgery is one of the coolest things about plastic surgery. We're always evolving. We're always learning how to be better and have longer lasting, better results for patients. And that is a very good example of it. The rates of capsular contracture from above and below the muscle in a lot of studies are pretty equitable now.
Yeah.
It's not twice as common as it used to be.
Right.
And so we don't see it that often. We do see it every once in a while.
I also think that like along with the device technology, we've also learned other kind of not tricks, but other like procedural things to do during surgeries to minimize that risk, right? I mean, we already talked about the inframammary fold incision, right? The inframammary fold incision, not choosing an implant that's too big for the patient. You and I already do that. Using a funnel so that it's a no-touch technique, meaning our gloves that have been on the patient, on the drapes, doing all that stuff, our gloves don't touch. It goes directly from the box that it was in directly into the patient's body. And using betadine, using perioperative antibiotics, using nipple shields, doing all these things that are just customary now. I mean, it's just part of it. So we're really seeing a whole lot less. It doesn't mean that you can't get it. Yep. We see patients that, I'm trying not to throw anybody under the bus with this. We see patients that maybe had not terrific decisions by plastic surgeons in the past that just put them like up against the wall. I mean, they're in harm's way just because of the implant choices that happened previous to that. And so, it's revisionary surgeries are always more complex. I've said, and you've said, I'm a better revisionary plastic surgeon because I do so much reconstruction, and I'm a better reconstruction doctor because of all the cosmetic stuff that I do. So it's really great that we both have that balance in our practice to be able to kind of meld the two different areas of breast surgery and functionally making us a better surgeon, which is what's awesome. Talk to us about what Motiva claims and if those claims are real and if patients need to really consider that when they're talking to us about their implant choice. Because I can tell you that if I thought Motiva was 100% better than Nitrel, I would only offer that, right? If I think they're kind of comparable, I tell patients the pros and cons about things and I kind of let them make the decision. So the Motiva device, as opposed to Allergan's Nitrel device, which has been kind of my gold standard for a long, long time. Mentor makes a beautiful device as well. Sientra has a device out. I haven't used it in a long time, but I think worldwide, in the United States, obviously Nitrel and Mentor have been the two big dogs. And then now there's this new, pretty shiny thing, Motiva. So talk to me about Motiva devices. You actually went down to Costa Rica and saw surgery and visited the plant and did all that kind of stuff. So talk to me.
Yeah, so Motiva claims several things, that how they have kind of evolved their implants to be better. One is the shell is micro textured. So, and they've studied this there's a big article in Nature. This is actually a very, very good study that they did that shows that the body recognizes it as less foreign and forms a thinner capsule. When you feel that implant, you feel that. But it
feels cool.
It does feel nice.
It's a great device. It's like the first time people have come and asked about a specific device.
Exactly.
You know? Okay, so then they talk about what does that do to their numbers as far as capsular contracture, and then the other side of it is the other implant companies say, yeah, but because you don't form that capsule, you're going to get malposition. So what do you tell patients about that?
Yeah, and so I think it's similar to other things that we've talked about. The concept is the same. Is it the device or is it our surgical technique? Right. And so Motiva claims that there's less capsular contracture, which I tend to believe that.
Yeah.
But also the other implant companies will say that there's more implant malposition because that capsule is thinner, and you do need a capsule to hold that device to give it some support.
Sure. You just want Goldilocks.
Right.
You don't want it so thin that it gives you no support, which would be the argument against Motiva.
Right.
But you don't want it so thick that it's like doesn't allow for a normal natural movement, which is what capsular contracture is. So it's like, what's that kind of middle ground? I also think that the other manufacturers would say Motiva's numbers are so much better because they had a modernized controlled study where those physicians, those surgeons were doing the sort of things that you and I are talking about that have become kind of everyday, like logical uses in breast augmentation.
Right.
And the older studies from the older companies didn't do that, right? It's like the Wild West. Put whatever implant you want in. Don't use antibiotics, do use antibiotics, throw your finger in there, whatever you want to do, right? And so it's just kind of different. So the studies, I think, aren't really comparable. But what are you finding in your practice? Because you use all of them. So specifically, are you seeing that malposition? And why don't you think you're seeing that malposition if you're not?
So, yeah, I haven't had any issues with malposition with the Motiva implants, but I don't have 5-year data on that.
Sure.
Which is, those types of complications like contracture and implant malposition tend to get higher over time.
Sure.
So
simple strategies is what I tell people to not have that malposition is what we've been doing for forever. I mean, I think you were trained this way, and I've certainly have told you since you've been here for the last 3 years. I want a hand and glove I want a precise pocket
So our
dissection.
surgical technique.
Right. And decision making, right? And you can have all the technique in the world, but if your technique is to open up a pocket bigger than it's supposed to be, well, you're going to get malposition problems, right? So, and then, not using crazy big implants on patients.
Exactly.
Being conservative with your implants, because what I don't think people need to do is think that, because I have people who come in and say, well, what about putting in some mesh, the internal bra? What do you think about that?
It's pretty common. A lot of surgeons use mesh. They use it pretty liberally. I've taken that mesh out before. So I'm always, if I can perform a surgery using your own body's tissue in a way to support the implant or whatever surgery I'm doing, I'm going to do that before I just throw mesh in there.
Yeah. I think for it to just be like
but there are patients who need it. So massive weight loss patients.
100%. I think it has
recurrent malposition.
Yeah. I think it has its use in patients, but I think in primary augmentations, in the patient who's not a massive weight loss patient, who doesn't have those kind of tissue issues, I think just throwing mesh in everybody is kind of crazy. It's costly and unnecessary, is my personal opinion. How about when patients say, how long will my results last? I mean, how many times, when am I going to need to get my breasts done again? These last for 10 years, right? That's what they say.
Depends. As long as you're, healthy, maintain a stable weight, and have a good surgeon and who's made good decisions with what implants to use, your results can last for a really long time. It's not necessarily 10 years.
Yeah, absolutely. And that data is old. And that data was like kind of junked up when they told patients that there's no shelf life or half-life on these implants. And barring you having major medical issues or weight gain, weight loss, pregnancies, and you take care of them, right? And we make good decisions with the choices that we use for your breast augmentation. I tell patients there's no reason to think you're not like going to the nursing home in these, right? You can always tell who in the nursing home has a breast augmentation. They have the most yellow cake and hot sauces on their table, right? because all the men are like rolling in there and like giving their hot sauce and yellow cake to them. Always, I'm telling you, it's 100% certainty. Yeah, you can quote me on that one. All right, let's take a deeper dive into some questions that go beyond this portfolio as well, right? So how does your practice integrate breast surgery into a comprehensive approach using a full body assessment and overall wellness goals?
Yeah, so I think that, our practice, and we've talked about this, we have, we can offer everything.
Yeah.
And we're very collaborative with each other, and we're always learning from each other, talking to each other about patients, and what their goals are.
Because what do you do about a patient that says, well, I think here's my wish specs. I think these look wonderful, but they're 30 pounds heavier and they tell you they want to lose that weight. Mm-hmm. When do you want to do their surgery now or what?
Right. Exactly. I mean, I want my patients to be in the ideal body weight. If you're going to lose 30 pounds,
right,
then your result's going to change.
It's going to change.
And then I don't want you to be mad at me when you lose those 30 pounds and your breasts are different.
Yeah, and your breasts are smaller.
So let's work on the weight first.
That's exactly right. And so that's what we're able to do to integrate that into our comprehensive approach, because we can do things. I've even had patients who have come in with stretch marks, right, to their breasts, and they don't need a lift. But they've got stretch marks. And so we say, well, hey, let's do a couple of rounds of RF microneedling to improve the quality of your breast tissue, your skin, so that it doesn't stretch, because it's just another kind of avenue to be able to kind of get a better, longer lasting result. With those patients, you also have to say, look, your breasts have stretched out. So it's not this perfect 100% skin quality. So maybe we need to lean towards the more conservative spectrum of what you'd be really happy with from a result standpoint. And it's critical that we talk to patients about these things.
It's hard for patients to get that and understand it. So, I mean, I do take a lot of time talking about these types of things so that they do understand. I want the best result for you to last the longest.
Yep. And deep dive question 2, what protocols do we employ here to ensure the safest surgical experience, and what accreditation? We just went through our accreditation process last week, so that's great. And,
so being Quad A certified and accredited as a facility is a big deal.
Yeah.
And there are places who are not. You want to go to a facility that really values that.
Yeah. I mean, because they look at the whole portfolio. I mean, they really
everything.
You talk about a deep dive. I mean, my God, they look at like everything. It's unbelievable. And so it's great. Once you're kind of checked off from them, you know that you're in a place that is top notch and that is dotting their I's, crossing their T's, and making sure that you have the safe experience. We also don't let patients, while there are some procedures that can be done under local, we don't push the envelope. We don't have to. We have our own Quad A certified operating room right here. We've got amazing anesthetists that are the best of the best, and they're going to be able to put you to sleep. They're going to be able to keep you safe, and which makes our job a whole heck of a lot easier and makes your recovery a whole heck of a lot easier also. I'll also say that we've got anesthetists who are trained in local blocks, right? Mm-hmm. So for breast surgeries in particular, you can go get, a chest wall block that's going to give you 100% comfort after surgery, especially if we're in this kind of subglandular, subfascial augmentation with the appropriately sized device through an inframammary fold. And you're going to feel so great. You're like, wait, why can't I go do X, Y, or Z? And we're having to hold our patients back from doing things, from overdoing it, because it's still surgery. It's major surgery. So you got to listen to us and heed our warnings so that you don't become one of those, stories that we remember. Mm-hmm. You never want to be a story that a surgeon remembers. You know what I mean? All right. Beyond primary surgery, specific expertise and training in complex revision cases, right? So you and I both have a huge composition of our breast practice that's revisionary stuff. We all get the patients that are like disasters. Mm-hmm. And come to you and say, I've heard you're the only one that can fix it, which isn't true. I mean, there's tons of great plastic surgeons out there, but it's great that people think that about us. But why do you think you get the results you get from really hard cases? What makes you
the devil's in the
prepared for
details?
that? Yeah.
So little things add up to a great result in plastic surgery, and it's not even the disasters. It's patients who have had 3 or 4 breast surgeries,
right?
A couple of different breast lifts and implants, bigger implants, going smaller. All those are tough surgeries to do.
Sure.
And so if you don't do all of the little things to tighten the pocket on the inside, tighten the skin on the outside, use the right implant, all those types of little, and I'm not even listing half of them, but lots of little things that we do in surgery that add up to a good result for patients, especially in these complex revisions.
Sure. And I've talked about it a little bit as far as like the recovery process for patients, and a post-operative care that gets managed. Obviously we see our patients, we follow up with them that night by a phone call. And then I used to see patients like, the next day, and then a week, and then 2 weeks. And that just got, exhaustive, not only for the staff here, but for the patients. They're like, why am I always constantly coming in? And then you've got a couple of patients who come in from out of town, and you realize, oh, wait, like I saw this person at 1 week, and then I saw them at 3 months, and they did great. So you're like, maybe I should do that with everybody. We're always available, and you and I have access to all hospital systems here in case something does go wrong or we have to meet our patient.
And I want patients I want them to let me know if they have a concern.
Yeah.
Little things can turn into big things if they're not addressed appropriately.
Sure. Oh, I'd much rather patients let us know early on if they're experiencing anything or have anything happen. And for some patients who just really don't want to take narcotic pain medicine and things like that, we offer their chest wall blocks to be done with Exparel, which is a 72-hour injectable. And so, you talk about having some numbness after a dental procedure for a few hours. Boy, wasn't that great, but when it wears off, man, that sucks. I mean, maximum swelling is in the first 48 to 72 hours. So we've got a numbing medicine that we can inject that gives you pain-free beyond that period. So it's like once you're on the other side of that, you're not having to take the narcotic pain medicine. You're on maybe Tylenol, maybe Advil.
Yeah.
I mean, maybe nothing. And then you don't have to worry about the constipation that comes with narcotics or kind of the loopiness or not being able to drive your car or anything like that. So, I have found that with kind of the way we have approached our breast augmentation, breast surgeries with these blocks, with our care plan, that like I'm having to tell patients to chill out more than I am like encouraging them to get up and move around. So that's just kind of what I have found out in my own practice, right? All right, so we've covered a ton here. There's obviously, you and I could talk ad nauseum. We've got both really big breast practices, and I don't mean like really big breast practices. You got to be careful where you put the comma in that, right?
Did the biggest breast reduction I've ever done in my life yesterday.
Wow, yeah. I did 3 reductions today. Yeah. Wow. All right. So today was a smaller breast day for me. All right. Schedule a consultation to discuss your goals and to find out more about breast augmentation or any breast procedure in general, as well as our integrative weight loss management system. Visit our website at g8surgery.com or call us at 704-375-7111. We are ready to take your calls and want to answer your questions. Your voice matters to us. If this episode sparked a question, or if you have a topic suggestion for a future episode of the Doc Dudes, don't hold back. You can easily reach us through ghrsurgery.com. Just click the dedicated Doc Dudes link on the homepage to submit your feedback or questions. Make sure you are subscribed so we pop up automatically. We drop fresh episodes on the last Tuesday of every month. Find us wherever you listen to podcasts, including Apple, Spotify, iHeartRadio, YouTube Music, and right on our own website. Finally, keep up with everything happening at our practice and get episode updates by following our Instagram and Facebook pages. We've loved talking to you about breast augmentation. We hope that this was informative and helped you. I am Dr. Garrett Harper with
Dr. Evon Zoog.
And see you later. Bye.